The role of chemoimmunotherapy is virtually non-existent in relapse refractory setting, with the exception of very few patients who may have had an extremely long remission after the first-line chemoimmunotherapy and are in a very good condition. I might consider repeating or using chemoimmunotherapy again, but these are extremely rare cases. Otherwise, in a relapse refractory setting, the targeted agents are basically the standard of care. Within the first-line therapy, the situation is a little bit different because in many countries, actually targeted agents are not yet available, meaning reimbursed for the first-line therapy, at least in some prognostic subgroups of patients. So that's one important factor, availability of therapy. And with regards to prognostic / predictive factors, I think that chemoimmunotherapy might still be a viable option for a very selected subgroup of patients who have a very favorable molecular prognosis, meaning mutated IGHV genes and the absence of unfavorable cytogenetics, meaning absence of deletion 11q, deletion of 17p, and of course absence of TP53, because it has been shown that various chemoimmunotherapy approaches in these patients, most notably the FCR regimen, but also BR regimen or chlorambucil plus obinutuzumab, may actually lead to a fairly long progression-free survival. So in these carefully selected patients, I think chemoimmunotherapy still might be one of the feasible options.